The liver transplant is the miracle of modern medicine. This is the established and the only definitive treatment for end-stage liver disease. Even though liver transplantation was established in 1981, the living donor liver transplantation did not start until 1999. The survival following liver transplantation is pretty good, which is 1-year survival is 87 to 93%, and 5-year survival is more than 75%, which is even better for living donor liver transplantation. Why do we have to think about shifting the paradigm to living donor liver transplantation? Why is this important? Because the disparity between the number of patients on the wait list and the number of available organs continue to grow each year. The total number of living donor liver transplant in the entire US is still less than 10% of the total number of liver transplants performed. It is time to shift the paradigm. And the number of living donor liver transplant in the US has not increased and is still very much underutilized. And we all understand and know that the living donor liver transplantation, the donor gives a piece of their liver to the recipient, and the liver regenerates both in the donor and the recipients in 12 weeks. The donor can be either biologically related to the recipient or could be an altruistic or non-biologic. And I just want to show that this is the current status of living donor liver transplant in the US. The number of patients on the wait list, this is the red line shows the number of patients on the wait list, and the dark blue line is the number of deceased donor liver transplant, and the light blue line is the number of living donor liver transplant in the US. So the number of patients on the wait list is anywhere between 14 to 16,000 for the last decade, and the number of patients who receive the deceased donor liver transplant is no more than 6,000 to 7,000 each year, and the number of living donor liver transplant is no more than 400 to 500 each year. So as you can clearly see, the number of living donor liver transplant in US is clearly underutilized. And this translates to the number of living donor liver transplant at USA is still proportionately low compared to the number of liver transplant, which is the total number of liver transplants, which is less than 10% of the total liver transplants done. So the median waiting time in each center, especially at UPMC, for the patients waiting on the wait list has been going up significantly each year. In 2015, this is number of these are the months. The patients waiting on the wait list, the median waiting time has been going up each year. And also the median meld, the median meld at which the patients get a deceased donor liver transplant has also been significantly going up each year. That means that the patients get the liver transplant, the deceased donor, at the point in time where they are very much sick. So the median meld has been going up, where the median meld at the point where the patients get a liver transplant at UPMC is around 30. And as you can see, the median time of waiting time has also significantly gone up also. What does this translate to? This translates to 15 to 25% of a chance of never making it to transplant for anyone at any point in time waiting on the wait list. Longer waiting period before receiving a transplant. A more debilitated state by the time a transplant is performed. A longer and more difficult recovery time post-transplant. And not all patients that would benefit are listed or offered transplant. This is what it translates to a patient who is on the wait list. This is the consequence of the wait list. So as I said before, this is the living donor liver transplant, which is very much underutilized in US. There is a spike in 2001. There were 500 living donor liver transplants, and currently there are 500. So it's grossly underutilized in US compared to the deceased donor liver transplant. And in the Western countries, the number of living donor liver transplant is not increased, but the demands of the organs continue to grow. In Asia, the problem was significantly and successfully addressed with the increase in the living donor liver transplant. But in US, in Eastern countries, these are the number of living donor liver transplants. But in US, the number of living donor liver transplants still remained significantly low. The number of hospitals in US that have done more than 100 living donor liver transplants is still only 15 hospitals have done more than 100 living donor liver transplants in total. And the UPMC is one of them, UCSF, Mayo, Rochester, New York Presbyterian. These are the hospitals who have done more than 100. But the number of centers, compared to the number of centers in US, there are more than 150 centers, which are transplant centers in US, but only 15 hospitals have done more than 100 living donor liver transplants. And there are, in 2020, this is the volume of the living donor liver transplants in the entire US. So the UPMC, we did 91 in 2020, and UT San Antonio did 38. And so this is the comparative volumes across the United States of America in 2020. So as you can see, the number of living donor liver transplants is still significantly lower. So there is a huge gap in the knowledge, and there is a significant underutilization of living donor liver transplant despite the benefits. And this is the volume of living donor liver transplant compared to the deceased donor liver transplant in UPMC. So in 2020, we did 91 living donor liver transplant and 56 deceased donor liver transplant. So the national average of any transplant center compared to their deceased donor is around 6%, but in UPMC, 60% of our total volume of transplants were comprised of living donor liver transplant. We made a concerted effort to increase the outcome, to improvise the outcomes and increase the volume of the living donor, because the living donor liver transplant offers better outcomes and also increase the accessibility of transplant to the patients on the wait list at the right time. So we had made a concerted effort as a team, as a center, to achieve that. And because of that, we had increased the living donor liver transplant volumes effectively for the benefit of the patient. And you can see at the UPMC, the same slide, we did 91 living donor liver transplant in 2020. And as far as the donor risk, compared to the UPMC data, we have not had any donor deaths at UPMC. There is no cases of liver failure, or none of the donors required any transplants. And overall complication rate is 19.5%. Major complication rate is 8.8%. The mean length of stay is anywhere between 4 to 7 days at UPMC. Compared to the national data, the major complication rate is 30%, and overall complication rate is 30%, and major complication rate is 10%. The donor outcomes at UPMC, reoperation rate is 6.2%. Biliary leak and biloma is around 1.2%, and recovery is 5 to 7 days in the hospital, 4 to 6 weeks desk job, 10 to 12 weeks physical job, 8 to 90% by 3 months post donation. They're back to their baseline. And what is new with the living donor liver transplantation at UPMC? We have done ABO incompatible and also liver paired exchange, extended criteria, altruistic, anonymous donation, and also champion program. The number of anonymous living donor liver transplant at UPMC by the year has gone up significantly. And this is because of our education and awareness, because of the public campaign, which we reached out to the entire nation talking about living donation. In 2019, 20% of our LDLT transplants were with an anonymous donor due to countrywide education campaign launched in October of 2018. We have also done liver paired exchanges. We have done 11 pairs of paired exchange from the year 2019 October through present. The swaps, these are called liver paired exchange. They were done in different combination. This was possible because of the altruistic donor. Out of the total cases, the exchanges initiated by an altruistic donor, all of them were involving an ABO incompatible donor-recipient pair with the matched donors for each recipient. The non-directed donor was blood type O in all of those cases. And the second recipient in these cases were chosen from the wait list. They were matched based on weight, BMI, melt, graft size, and anatomy. Both the pairs underwent transplants within a week of each other. So this was only possible because of an altruistic donor. The person came forward, and they were O blood type, and then we were able to match them with a different pair. So we have done at least 11 of them. And liver paired exchange or liver swap is possible because recipients would otherwise have no option even with the donor. Altruistic donors were used for the first time in USA for liver swaps. 11 pairs, which are 22 lives, were saved thus far. We also have a champion program which is unique to UPMC. The conceptual framework of the Living Donor Champion program consists of a multi-pronged approach utilizing the family, the extended network, and the community and the support system. It is a structured education and awareness program including targeted education, utilizing the social media, and incorporating education webinars, and also with our advocacy groups, including CLA, UNOS, Donate Life, and CORE. And Living Donor Champion program has a multiple components, including Champion Toolkit, Facebook support page, Living Donor Town Hall, information sessions, and Facebook page. And we also have the support from the Champion Ambassador with the one-on-one coaching, Living Donor education and information session through the Facebook page, webinar, public education efforts. The most key part is the ambassador who supports the champion through one-on-one. The champion is a person who's identified by the recipient who's on the wait list or who's undergoing the evaluation, and this champion is a identified person within the recipient support group, and the ambassador works through the champion who then utilizes the multiple resources offered by us in identifying a donor for the recipient. And this has been an extremely successful program because it takes the pressure off of the recipient in asking for help. Instead, the champion works with us in identifying a donor for the recipient instead of the recipient doing all the work. And our Living Donor Champion program has multiple components, including the champion events, the social media, the champion support group, and the champion website. And we started this on June of 2017, and we have the data until May of 2021, and we have had several champion events, including town hall and workshops, and we have also several social media engagements, champion support. Currently, our ambassador is working with more than 100 champions, and we also have a robust champion website. And because of the Living Donor program offering early access to transplant for the patients on the wait list, we have significantly reduced the transplant patient mortality on the wait list and increased the access to transplant for the patients on the wait list. Our transplant waitlist mortality has significantly reduced, as you can see on the bar graph. And we also have increased the number of patients who got transplant in the last few years. The transplant rate also doubled, as you can see. And the recipient, this is the recipient and the graft survival and the patient survival. The red is the deceased and the live is the blue. And as you can see, there is a significant survival benefit and the graft survival benefit with the Living Donor liver transplant, as both the curves show. And also there is a significant reduction in the cost and the resource utilization data between the Living Donor liver transplant and the deceased donor liver transplant, where the number of outpatient labs, the pre-transplant costs, the inpatient perioperative costs, the total post-transplant costs, and the reduction in the inpatient readmission rates, and the outpatient pre and the post-transplant costs, as you can see, compared to both the living donor and the deceased donor liver transplant. Not only the living donor liver transplant increases the accessibility to transplant, reduces the mortality on the wait list, improves the quality of life, but also reduces the morbidity and improves the quality of life for patients on the wait list. And that reduces the retransplant rates and also improves the outcome. And also there are better outcomes on patients with the living donor liver transplant, as you can see. And so, in summary, living donor liver transplant comprised 53.6% of UPMC's total transplant. The transplant rate increased from 44 to 103 in 2019. So the criteria for living donor liver transplant should be based on ability to provide a survival advantage and the quality of life improvement. And living donor liver transplant is not the last resort, but rather the first and the better